Now we hear you.
Yes.
Now we hear you.
Yes.
Finally. I don't see it.
Right.
Okay, good morning, good afternoon, good evening. We have people from Japan to China to Europe, US, across the world. And it's great to have you back for the fourth INTAM webinar. So, some basic things. Please mute yourself when one self talking, getting sure that there will not be a circulation of the voice inside the meeting room. I have colleagues that are going to help in terms of muting some others, that just getting sure that the room would be silent enough for people to talk. Today we are going to have the fourth INTAM webinar. And it's great to have people from kind of countries across the world, and we are hopeful that this meeting is going to be kind of a good platform to discuss about potentials with brain stimulation technologies for addiction medicine. So that is the idea that we have for the meeting. Right now we have, let's see, 90 attendees, probably from different countries across the world. We usually kind of ask people who are from kind of different labs to just introduce themselves and kind of say what they are doing right now in different places. We do not have very much time today, but probably few people could just introduce themselves to just kind of start with few introductions and kind of having an idea about different labs and what they are doing across the world. So Vincent, could you hear us? Vincent One Ways, could you kind of tell us where are you from and what are you doing?
Hello, can you hear me?
Perfectly,
okay.
Yeah.
Hello, everybody. I'm Vincent Van Waes. I'm working from France in the laboratory of neuroscience in the University of Franche-Comté. I'm working on the impact of repeated anodal transcranial direct current stimulation on addiction-related behavior in rats. And I'm pleased to be with you today.
Good, good. Bernard, do you want to introduce yourself?
Sure. Hello, everybody. Bernard Le Foll, I'm clinician scientist at KMH, Center for Addiction and Mental Health in Toronto. So I'm doing clinical trial in various addiction, but for TMS, my interest is on the insula and smoking cessation, and it's a project involving Bumi also. Hi, Bumi.
Okay, good. Michael Wesley. We cannot hear you right now. Okay, Adrian, do you want to introduce yourself? We cannot hear you. You should unmute yourself.
Okay, I'm Adrian Abadiou. I am an infectious diseases physician working with addiction since 15 years already. And I'm also one of the ISM newsletter editors. And we have some problems with the COVID and the methadone maintenance treatment. Unfortunately, since October last year, we don't have any more Suboxone, and nobody is interested to bring it back to the patients, and this is not good.
Okay, good. Akimasa, do you want to introduce yourself?
Hi, my name is Aki Hirata from Japan. So our group is doing the computational modeling of TMS and tDCS. Thank you.
I love you. Flavio, could you hear us?
Yes. Hello, everyone. My name is Flavio Frolic. I'm at UNC at Chapel Hill in North Carolina. I'm director of the Carolina Center for Neurostimulation. I'm interested in mechanisms of brain stimulation, specifically to modulate brain rhythms, from mechanisms to applications to clinical trials and all kinds of translational applications.
Han Bing.
Hear me?
Yes.
Hello. Hi, yes. I'm working at the National Institute on Drug Abuse, NIDA. I'm developing focal TMS technologies for animals, and we're conducting animal trials using TMS for treatment.
Good, good. The other people that they have their camera on, Saeed, do you want to introduce yourself? We cannot hear you.
Is that okay?
Yes.
Can you hear me, Doctor?
Yes, yes, yes.
This is Said. I'm a PhD student in biomedical engineering and cooperating with a national brain mapping laboratory in Iran and also with RTA clinic with Dr. Rosami. Actually, at this time, I'm working on effects of TMS on depression with Dr. Rosami.
Okay, Lori.
Hi, I'm Lori Zavarchilo from the Centre for Addiction and Mental Health in Toronto. I'm currently doing a clinical trial on looking at improving the efficacy of varenicline using tDCS.
Okay. Pradeep. We cannot hear you.
Myself, Pradeep Agassia from Ahmedabad, India. I'm working with mostly as a psychiatrist and addiction medicine, and particularly I'm treating my patient with the pharmacotherapy as well as the motivational enhancement therapy and CBT. I have a little experience with whatever the content today.
Okay.
Thank you.
Thank you. Good. Now let's go for kind of the first kind of ideas that we are going to have today. We have the fourth INTAM webinar, and we are going to have recent updates on potentials for shared protocols in the field. Till March 17th in 2020, we have 69 TMS studies and 48 tDCS studies across the world in the field of addiction medicine. So we are trying to follow the labs that are doing brain stimulation studies in different kind of fields of addiction medicine and what they are publishing in different journals. This is the map that we have from the labs that are already working with the international network of tDCS, models for addiction medicine. So this is the INTAM map and collaborators that are kind of contributing to INTAM. For those who are kind of new to the INTAM webinars, we have published a consensus paper on basically potentials and challenges for the field of tDCS for addiction medicine. That consensus paper is already available for those who are interested to have an overview about what we have done so far. And we have recorded 3 previous webinars, and we are recording this fourth webinar. For those who are interested to have a rapid overview about what people have done, you can just go to the INTAM YouTube channel and see all the videos that we have recorded so far. And I think that if you start to see all those videos, you can have a really good idea about the things that are happening across the world and potentials and challenges that we are facing. We have recently put together a guideline for TMS, tDCS clinical services and research during the COVID-19 kind of era. And I really enjoyed working with, people like Marom, Colleen, and those others who are already kind of online right now. Marom, could you just give us an overview about what we have done for that specific guideline? Do you like to talk about that for a few minutes?
Sure. Again, this was something that Hamed really put together with some of these authors, and it was something that was done, I think, in like the middle of the night for many people as we struggled to get this out as quickly as possible. And so this is really a rapidly assembled guideline on how to maintain, restart or even expand brain stimulation operations in the time of COVID. And the document is written in a way that emphasizes that it is absolutely critical to do so. So it's not ambivalent. It says that we ethically need to maintain these services. We ethically need to maintain research, and it tries to provide a checklist, guidances, steps that you can follow in order to do so. It's intended to be a document that if you're dealing with your IRB or other local administrators, you can share with them in order to support your efforts to reestablish it. And again, I don't think this document is perfect. I think it was the best effort of these authors. But we do hope that it's going to be something that's valuable. And we also hope that, other people we hope that other people continue to share their own experiences and publish their own recommendations. So we also hope that this document is just one of many that people put forward to sort of support the community.
Thank you very much, Marom. And it is going to be published in Brain Stimulation. Today, just a few minutes ago, I received the initial proof copy of the manuscript in Brain Stimulation. So hopefully in the next coming days, it is going to be published. Right now, it is available in Psych Archive. So we will share the link to the document in the chat space. So if you want to kind of have an idea about what is happening there, you can have access to the full document. And we are still kind of updating the document in the process of kind of receiving feedbacks from others. Okay, today we have speakers from across the world. We have Bumi from Israel. We have Tifei from China, Colleen, Rita, and her postdoc, Pierre Olivier. We have Vince. We have Elliot and his PhD student, Sarah. And I will be talking with Ghazale about what we have done in terms of kind of new advances for using brain stimulation technologies in different areas of addiction medicine. So without any further ado, we will go for the first speaker. That would be Abraham Zangen from Ben-Gurion University. And for each talk would be basically 10 minutes talk with 5 minutes time for basically question and answer. And I hope that kind of speakers would kind of be careful about the timing, getting sure that we will be able to have all the talks in the kind of the timing that we have, limited timing that we have for the webinar. So let me just give the screen. Panel, would you give the screen to Bumi to just getting sure that he is going to share his screen?
Yep, sure.
Hey, hello everyone. And I want to make sure that you hear me well. Some feedback from you, Hamed, or anyone? Hello?
Yes,
Yeah,
we are hearing you really well.
Okay. Yes. So I will try to briefly present to you the results of a multi-center study in smoking cessation. Let me see. We did a study to evaluate the potential of high-frequency stimulation delivered to the prefrontal and insular cortices for smoking cessation. Just some introduction. We know that smoking is a leading cause of preventable disease and deaths worldwide, and multiple serious health problems and high economic burden it causes. And we also know that based on a recent study published in New England Journal of Medicine, which included more than 6,000 participants, the ability of pharmacological interventions is very limited. Although there were some FDA-approved drugs, when tested in a large study, the one that published recently in New England Journal of Medicine, we see that the rates of real quitting is very low. And usually, if you just take the medicines, it's less than 10%. A very, very surprising study published in the New England Journal of Medicine, where many participants were enrolled. We also know many studies, I'm just citing one here, that acute TMS applied to the prefrontal cortex can induce a reduction of craving to smoking and to other drugs of abuse. And we also have some previous studies from my group showing that chronic, so multiple sessions of TMS, particularly when using deep TMS, we also used in the first study figure of 8 coil, can reduce smoking consumption and even induce long-term effect when multiple sessions are applied. So why do we need the deep stimulation? First, we know that the insula is a major area that we would like to target This is a famous study published in Science showing in cases of stroke that when the insula was damaged, then smoke stopped smoking, while other areas in the brain were damaged. We don't see a reduction in smoking. Also, from our lab, animal studies showed we used usually models for cocaine self-administration in rats, or the psychomotor sensitization model, showing that if you stimulate the prefrontal cortex, but not some other brain regions that we tested in this study published in Journal of Neuroscience already in 2007, you can reduce the craving and the motivation to consume cocaine. But this, again, is only after multiple sessions of stimulation. And this was particularly efficient when the electrode was implanted into the prefrontal cortex, and more so when it got down to the infralimbic cortex. This is a new study from our lab that shows that if the electrode is implanted into the infralimbic cortex rather than the prelimbic cortex, meaning deeper layers in the prefrontal cortex, then you can reduce relapse rates to cocaine in an animal model. We also measured some molecular correlates for that, like the GLUA1, the AMPA receptor subunit GLUA1, showing some correlation with these effects, that the multiple sessions of stimulation can make alterations on the opposite direction of what chronic exposure to drugs, in this case, cocaine. So we use the H4 deep TMS coil. If you see here the distribution of the electric field induced by a pulse from a figure 8 coil or an H coil, you see that the H4 coil, the one that we use targeting both the prefrontal cortex and the insular cortex, induces bilateral stimulation and larger volume of stimulation. This is coming from phantom brain measures. The figure 8 is focal, and the ability to reach deeper is coming on the expense of focality. So we stimulate larger volumes of the brain. Our original study, well, I will get to our original study, but just say now that our first study targeting smoking cessation used the figure of 8 coil with some positive signal, and the stronger signal was observed in a later study we published in Biological Psychiatry using the H4 coil, and that led us to the multicenter study. So the multicenter study was conducted by on 226 heavy smokers. Each subject was admitted for up to 4 months. The PIs of the study were Mark George and myself, and there were many other sites involved, altogether 14 sites globally, mainly in the United States. We had 2 sites in Israel as well. We used high-frequency stimulation, and the outcome measures were both self-questionnaires and urine samples to measure cotinine levels. We also used provocation prior to each stimulation session, and the reason for provocation concept is coming from several evidences in the literature. Maybe the first one comes from the memory literature, showing that items that are stored in long-term memory become more prone for change upon the retrieval. So we want to activate the circuit that we want to change by the stimulation. We also showed it in a paper from our group by Steberg et al. In a model for memory, for traumatic memory. And there we show that only when we combine the stimulation, in that case, electrodes implanted into rats, together with retrieval of the memory, we were able to change the memory to in that case, partly erase the traumatic memory. But when the stimulation was applied without the provocation, without the reminder of the memory, then there was no lasting effect. So these are early publications supporting the reason for provocation. We have also a study in humans, also in the memory area, PTSD patients, where we had 3 different groups, one receiving high-frequency stimulation to the prefrontal cortex with provocation, with recall of the traumatic memory, another group receiving the same parameter without the recall, another the recall. So when you do the recall by itself, it doesn't do much if you look at pre and post. But the same, in this case, TMS didn't do anything to the PTSD patients. But when you combine the provocation, the recall of the memory, and the stimulation is when we got the effect. And this is also a published study from our group. So now the first study was done with a figure of 8 coil. We didn't have at that time the ethical approval to do it with the H coil, with the deep TMS coil. We use a standard figure of 8 coil. This included 48 participants. And we already had a positive signal after 10 sessions of stimulation, 10 days, 2 weeks, with the provocation or without the provocation. It didn't make a difference in this case. We had a reduction in the number of cigarettes or the nicotine levels measured in urine in the active groups. However, this intervention did not induce complete quitting. There was a very clear and significant reduction in smoking behavior with the figure of 8 targeting the left prefrontal cortex, but no quitting, and there were also no significant lasting long-term effects. So this was published in Addiction in 2009 from my group by Amiazabal. Then in a later study, when we finally did get ethical approval to use the H coil for smoking cessation, we used this H4 coil that I showed you earlier, targeting both the prefrontal cortex and the insula. And we did, in this case, we increased a little bit the timing. We did a third week with 3 more sessions, altogether 13 sessions. And there you see the consumption going down along the time, both as measured by number of cigarettes or by urine levels of nicotine. And here we did get quitting. We had a nice rate of quitting, particularly in the 10 hertz group. We also had a low frequency group, but the high frequency group had the best quitting rate, the best reduction in consumption in cigarettes as measured by nicotine or self-reports. And here also we had already a very clear trend that combining the cue, the provocation, just prior to each stimulation session induced a greater effect of quitting relative to just using the 10 hertz without the provocation. Long-term was not really measured very properly just by phone call, so there was no nicotine levels. 6 months phone call asking for how much they smoked. And this is the study, the second study we published in the clinical one, published in Biological Psychiatry by Dinu Klein et al. So this led us to this multi-center study that I will briefly discuss here. The protocol was similar, was replication of that earlier study by Dinu et al. We had 3 weeks of treatment with the H4 coil targeting the prefrontal cortex and insular cortex. Then and again, each time we did the provocation. Before, this is the content of the provocation with smoking pictures and other cues. So we then, before each session of stimulation, then we had a follow-up for additional 3 weeks. And then for those who managed to quit in the follow-up, we also invited them for a long follow-up at up to 4 months. But the primary outcome was here at the short follow-up. Here we had very intensive measures of nicotine levels and self-reports, and this was the timing of the primary outcome. These are the parameters that we use: high frequency, 120% of motor threshold, number of trains. So it takes 20 minutes per day of stimulation, including the provocation time. We also had, after each session, 2 minutes of some motivational script, clearing the air, like motivational script, why do you want to quit smoking? You should quit smoking, and so on. So this was the timeline for each subject, and this was the altogether the demographic data of the multi-center study. We had, as I said, 14 different centers globally. The subjects that entered the study were typically very heavy smokers. Look at the number of years of smoking in average in the active or the sham group. And at baseline, there were no differences. And these are subjects that tried usually to quit several times. They had several quitting attempts. Most of them had more than 3 quitting attempts with different drugs or other methods to quit, but failed and came to our study to try something else, something new, non-pharmacological. This is a CONSORT diagram, the number of patients enrolled, 262, and we had altogether those who completed, you see here the numbers, those who completed the short follow-up, and the primary outcome measure was a continuous quitting of 4 weeks. That was the requirement of the FDA, continuous quitting, so that we have every week nicotine levels showing no smoking plus self-report no smoking. So if a patient subject stopped for 4 weeks, there was clean urine, then it was considered a quitter, and even then took further for some longer follow-up for up to 4 months.
Bumi, you just have 1 minute left.
Okay, so I can stop here and tell you that we were very happy with the results, and I'm open for questions.
Good, great, good job. We are able to take we have close to 2 minutes for questions, if there is any specific question that people are going to ask. Colleen.
Can you hear me?
Perfectly well.
Excellent. Bumi, I know, awesome data. Thank you so much for sharing it with us. So I noticed you had 18 sessions, but then you did 5 days a week. And then for the last few weeks, you just did 1 session per week. Do you think those 1 session per weeks were necessary?
Yes, they were necessary. I don't think for the maintenance of the effect, but they were necessary to induce, make sure that we get the subjects to come. I think this maintenance is causing subjects to understand that if they don't come, they might lose the effect, and having them, telling them that they are coming for another session of maintenance treatment made it reduce the dropout rate, so that we get, the nicotine levels, the urine samples from them. And I think in studies that are designed for multicenter, if you want to have a follow-up and you might make sure that you don't lose the subject during follow-up, it's good to bring them in once a week maintenance treatment in order to increase the preservation of the subjects in this study, taking as objective measures like urine samples.
No, thank you. Thank you very much. Now we need to move forward for the next speaker, and the next speaker would be Tifei from Shanghai. Let me just, my assistants would give screen to Tifei.
Now he's in the presenter mode.
Okay, Tifei, you can share your screen. Please introduce yourself.
Yeah, I still couldn't share my screen, so.
Let me check once again. You are in the presenter mode. Yep, we can see that.
It's a full screen now?
Yes.
It is, yeah, I mean, just put your slides in the presentation mode and everything looks perfect.
Yeah, I already did it.
Okay, good.
Do you see full screen now?
Yes, yes.
Okay, so I will switch off my video. It's might be faster. So hello everyone. It's a good pleasure to share you some of our recent studies on methamphetamine. Why it's not moving? Okay, you see next slide?
Yes.
Okay. So the outline of my talk will be, first, I want to mention that we can either use single or pair pulse TMS that we can probe the cortical plasticity changes in drug addiction. So the second thing, we can use repetitive TMS. We can treat the method dependence. So to start, I'm showing you that we can do some animal research that is, for example, with animal self-administration with methamphetamine. And then we can cut the brain into different brain slices here. And then we can record different cortical regions. For example, if you record from the motor cortex and you give the stimulation electrode on brain slice, and then you can record the field potential evoked plasticity on the brain slice. So basically, you can see all the black points. They are recorded from saline treated animals, and the red are the methamphetamine self-administration animals. So basically, you can see that we can have both LTP and LTD, which means you can have cortical potentiation and depression in normal animals, but you cannot see such thing for the meth-dependent animals. And then we can use TMS as a tool to prove the translational insights. For example, if we can perform the 10 Hz plasticity protocol on the methamphetamine dependence, you can see that in the black trace, you can see actually the LTP-like changes in the healthy subjects, but in the methamphetamine dependence, you do not see this similar change. Also with CTBS, normally you can see induced LTD on these healthy subjects, but in the methamphetamine patients, it's actually impaired. So we also note that the plasticity will recover after like 2 years of rehabilitation, and the amount of plasticity actually inversely correlate to their craving score or other clinical symptoms. So this tells us that maybe we can use the cortical plasticity measurement as a potential function or potential correlate to the clinical severity of the addiction. So we also found that if we identify the impaired motor cortical plasticity, if we subject animal or human patients to the motor learning task, we see that in the black trace, we see the normal learning curve, but in the meth dependents or the dependent animals, you see that the motor learning results is actually impaired. So this does suggest that if you have the impaired cortical plasticity, you might have impaired learning or the impaired ability to adjust yourself or the ability to change your own behaviors. So this might explain why the drug dependents are unable to change their or modify their existing behaviors. So we are actually ongoing many molecular studies that we are actually looking at one subunit of the AMDR subunit receptor, which is gluing-3, and it's a less calcium permeable subunit for AMDR receptor. And we believe that its insertion after the drug addiction in the red bar is mediating this anti-inhibiting plasticity and might contribute to the drug dependence impaired synaptic plasticity. So the next stage is that we try to map the cortical plasticity changes in the drug dependence. Here, I'm showing you that we collaborate with Amit Atkin from Stanford, and we are using a TMS CEG to map the cortical plasticity over the brain in methamphetamine dependence. So basically, we are stimulating in the F3, F4, and P3 points. And at each point, you can use the TMS evoked potentials to map the cortical connectivity. And then we can apply the traditional or classic, the treatment protocol onto the F3 point, which is the prefrontal cortex. And then we can compare the cortical plasticity induced at the prefrontal cortex. So here I'm showing you that this is the beta oscillation evoked by single TMS potential, which is the calculated by post plasticity protocol. So all the color you are seeing here is meaning the plasticity after a single 10 Hz protocol for 2,000 pulses. So basically, you are seeing that here in the control subject, you are seeing a lot of beta here, but reduced here. However, in the methamphetamine, you clearly see that in the late phase of the beta oscillation, you see a lot of plasticity induced. So this change, the altered plasticity response, could also explain what we are seeing in the different prefrontal functions in the methamphetamine dependence. And now we are trying to generalize our finding to different cortical spots, and so that we can map the cortical network difference. So the third thing we are trying to do is, based on all the cortical findings, we are trying to promote the cortical plasticity-based treatment for methamphetamine dependence. So I'm showing that here we can find that with the 10 Hz TMS at DLPFC, we can actually reduce the craving, improve the sleep, and also elevate the withdrawal symptom. Notably, you can see that, so here you can see the change in sleep score is correlated quite linearly to the changes in craving. And this is in acute withdrawal patients. And in the longer withdrawal patients, we can see that the changes in sleep score is also correlated well with anxiety and depression score. So also I'm showing that so methamphetamine is characterized by the strong impulsivity. And so here we are using improved measurement for the impulsivity, which is the modified form from the go-no-go task. And it provides both the reaction time and also the accuracy measurements. So here I'm showing that so in health, compared to the healthy control, you can see that the accuracy of this task in methamphetamine, it has actually decreased. And also their response much faster, which means that they are making premature judgments and are more impulsive. And with the 1 Hz TMS at the left side, we can see that just with single session, we already see some response in accuracy, also with the reaction time, which is not showing here. And also with after 10 days treatment, and we can see the lasting effects for another 3 weeks for follow-up. So this give you idea that we can not only use the TMS to treat the craving and reduce the wanting for drugs, but maybe we can also reduce the impulsivity and increase their behavior control. So maybe they can behave well and reduce their impulsivity for the relapse. So also we are showing we try to screen more behavioral measures for the cognition. For example, we are screening for the working memory, because also other people are showing that with TBS or TMS treatment, you can actually improve the working memory in the methamphetamine dependence. So here I'm showing you that with the 2 times daily ITBS treatment for 10 days, which is the 20 times treatment, and we are using the N-back test for the methamphetamine dependence. You can see that for all the 3 levels, 1 back, 2 back, and 3 backs, you have improved accuracy, and also the discrimination index is actually increased. So here you can see that it's indeed increasing the ability for working memory. And we also perform a little bit more on the potential neurobiomarkers. So basically, we are performing the resting EEG before and after treatment. So this is for the baseline, and this is after treatment, and this is the sham group and after treatment. So basically, I'm showing just one data is that the changes in the resting delta power correlated well to the working memory accuracy. So it's just one preliminary finding, and we are also trying to understand more what kind of baseline biomarkers could be used to predict the treatment effects. So to briefly conclude, the cortical plasticity is associated with many things. For example, it could be associated with the memory and maybe the other like impulsivity or mood disorder or sleep disorders. And we might use the single pulse combined with MEP or EEG that we can map the cortical plasticity, and then we can understand the connectivity difference in different patients. And also that we can use the TMS as a treatment tool that we can modulate the cortical targets, and we can trigger a lot of downstream and network changes because we are short of the MRI structure or brain imaging measurements here. We are more likely to be based on the EEG measurements. So I believe there are many other ongoing literature showing that with the cortical TMS treatment, you can actually trigger a lot of subcortical network changes, and this could be underlying our TMS effects. So because of the time is short, so I'm just briefly showing you all the related works generated from our lab. So maybe you can take a look of the literature if you're interested. So basically, we are using the TMS-based measurements. So far, we just published on the motor cortex plasticity with the MEP measurements, and we are going to submit our work on the TMS EEG shortly. So this is both for methamphetamine and heroin, and also for the treatment. So the first one is actually published on animals that we are showing that ultrasound stimulation is can also reach quite deep brain regions such as nucleus accumbens. And we believe that this could be another way to non-invasively stimulate the brain. And also other papers are with the methamphetamine or tDCS, also with heroin studies.
Thank you very much.
These are all the collaborations. Thank you for attention.
Thank you. Thank you very much, Tifei, for being on time, and lots of really exciting studies in the field. We probably can take one question for Tifei if it's going to be very short. Okay, let's move to the, please.
Tifei, I'm just wondering, I don't know if you discussed it, but there are a few people in all groups that do not show any response for the TMS. And, that it's not a bad thing. It just means that the treatment should be individualized, as you said in your discussion. And I wonder, how do you explain the non-responders? I mean, is it because they need more sessions of TMS, or is it a dose issue, or is it underlying structural psychopathology, or something like that? That I wonder what it's driven by.
Thanks for the question. I do like this question. So there are several possibilities, and I think by each system we can explain this question. For example, with structure, we can explain that we are targeting different cortical network, and by functional connectivity, we can mention that we are not using the individualized oscillation, or this TMS is not triggering the best plastic response. Also, we can say that this subject could react better to another frequency or something else. To me, I think it's something unknown, but just to give an explanation that so everyone, I think, working on different systems, they can explain this from their own perspective. For example, people are saying you can individualize your target, you can individualize your treatment frequency, and maybe all of them can have a better effect. But the problem is just we are lacking enough evidence. I think we are seeing many evidence from depression treatments, but no one are trying enough different protocols or stop one protocol and exchange for another protocol to see if you are seeing improved effects. I think we just need more work, and we're just repeating many things we found on depression studies, and we can translate them directly for addiction. So that's
Thank you. Thank you very much. Yeah, that's really politically correct answer to the really big challenge that we have. And Colleen, you are going to be the next speaker, so just getting sure that you will have enough time for your talk. Thank you very much, Tifei. Just getting sure, Colleen, could you share your screen? Okay, perfect. You can see your screen. Please unmute yourself.
Got it. You hear me?
Perfectly well, yeah.
Great. Thank you so much, Nelly, for that question following Tifei's talk. That's a perfect segue into this talk, which is biomarkers influencing the efficacy of TMS on addiction. And Hamid, thanks for inviting me. Although I will say that this is easily an hour-long talk. So I'm going to do my best to teach you something in about 10 minutes. But my hope is that since the slides will be publicly available, if you want to learn more, I included a lot of references that you could go and read more if you want.
Colleen, you're mute right now.
Goodness gracious. Does that work okay? Okay. So relapse is a really big deal. We're familiar with this, of course, because this is what we all do. But I do think that it's good when you kind of speak about this to other people to remind them that this is just like any other chronic disease, right? Relapse rates are even higher than for diabetes, for hypertension and asthma. They're comparable. And just like all of medicine is looking at sort of precision medicine and figuring out which treatment should work for different types of patients, that's why we should invest in. And so I would be remiss to do this talk without talking about factors that influence relapse for addiction itself. There's been a lot of people, in fact, some of the people on this call that have contributed to this literature. One of my favorite review articles was recently published by Scott Moeller and Marty Paulus. It's open access, which given the international community on this call, I thought was a good thing to include. So if you want to know a little bit about brain-based markers that influence relapse, I would highly recommend that you look at this publication. And to summarize what they find, essentially, brain reactivity to drug cues and prefrontal gray and white matter are salient, strong factors to predict relapse. And that's going to be the theme of this whole talk. The answer to the question is both function and structure influence relapse to addiction and TMS efficacy. We actually also published another article, which is very similar, if you want sort of just another source. And again, a lot of people have invested in this and shown that various frontal and striatal networks, specifically connectivity in these networks, both at resting state as well as during tasks like cue reactivity or even executive control tasks, are related to the likelihood of relapse. Okay, and now if you turn our idea to TMS. So we know a little bit about the brain metrics that influence relapse in addiction. So what factors influence TMS efficacy? And this is a slide that we typically use when we teach our TMS training course. I was at MUSC and we had a good training course. And basically I summarize this by the word fields. We have frequency of TMS, of course. We have the intensity of TMS, usually a % active or resting motor threshold. Engagement. So this is what somebody is doing before or during TMS. You saw Dr. Zangen's really elegant presentation of the huge body of work they have done showing that engagement in the task or priming of the brain is important for TMS efficacy. And again, this relates to a factor that influences addiction relapse itself. How is the brain reacting in a functional state? Also, in terms of factors that influence TMS-associated change, we have the length or the distance from the scalp to the target. Some people, I was recently talking to Engel Petrushev, and he seems to think that almost all of the variants in TMS-related effects probably could be summarized by the distance from the scalp to the cortex. And now we have new tools like SIMNIBs that do really elegant modeling of the electric field distribution. Just calculating the distance from the scalp to the cortex with neuronavigation tools is also, in our analysis, one of the factors that sucks up the highest amount of variance associated with TMS response. And then duration and the shape of the coil. But again, I want to highlight functional activity and structural integrity as salient biomarkers for TMS treatment effects. Riding and Zeman published a very nice review article a few years ago that kind of summarized studies in a meta-analytic way of determinants of brain stimulation-associated plasticity. And what they found, this is kind of an odd graph, but things that are on the top of the graph, kind of in a positive way, encourage or increase the likelihood of plasticity, whereas things that are pushed down more towards the bottom decrease the likelihood of brain stimulation-related plasticity. And what you see here is maybe females are a little bit more likely to respond to brain stimulation at large. The primed brain in terms of aerobic exercise or attentional focus also increases functional activity and brain response to TMS and tDCS. Time of day and the age. So the ages are where we come in again with this cortical atrophy and distance from the scalp to the cortex. So younger individuals, which have kind of a more, they have less atrophy, are going to respond better. And when we're talking about this in terms of addiction, we know that some populations with addiction, including individuals with alcohol use disorder or heavy alcohol that's embedded within cocaine use or methamphetamine use, causes severe cortical atrophy. And consequently, we probably are going to need to use a higher TMS dose or percent machine output in order to reach the cortical target we want to engage. And so when we choose a TMS target, we have all of these different circuits that our sort of fathers before us have come up with, right? These are cortical striatal circuits. And as Tifei mentioned a second ago, some of the variance is just related to the specific circuit that we're targeting, and particularly how the cortical and subcortical circuits are working together. So that's a little kind of summarizing what's out there in terms of factors that affect relapse for addiction, factors that affect efficacy of TMS. And now I'll show you a little bit of real data that has come out of our lab. So we just finished our biggest study to date of a 10-day active sham-controlled study of TMS in treatment-engaged cocaine users and alcohol users. In this case, they received brain imaging before and immediately after 10 days of TMS, which was delivered to the medial prefrontal cortex, as well as a 1 and a 2 month follow-up visit. These data are hot. They're not even hot off the press. They haven't even been submitted yet. But this is the general CONSORT diagram. And for the sake of time, I'll just draw you to the idea that most people completed all TMS visits, both real and sham, 84%. Which is pretty great. When we look at the demographics, you can see them above. And then when you do kind of classic clinical trial statistics with the intent to treat sample, you can find that the odds ratio of relapse at 3 months was different between the groups, such that the likelihood of sobriety in the 3rd month after treatment initiation is increased almost 2 times in the individuals that receive real TMS. So in my hands, I feel like that's pretty good. I mean, it's not perfect, but it's not too bad. What we found, of course, however, is that there's a huge amount of variability. We tried to do it the kind of classic way. We had this conceptual model, which we had aggregated data from many, many people. We found a target. We used SIMNIBs to sort of figure out where our target would be. And we placed the coil on approximately the left frontal pole for everyone. So that was our target. We were going to engage it. We got reasonable results, I think, for a study of this size. But when we go back and we look at the inward hot spots for drug cue reactivity, which, as I told you in the beginning of the talk, drug cue reactivity itself is a predictor of relapse. Sort of the hot spots for cue reactivity were all over the place. And this is one of the problems with all of us that do neuroimaging, and we just take the group average. Because in fact, there's a lot of individual variability. One of the factors that we saw that differentiated this sort of locus of cue reactivity the most was actually gender, with females in this sample of alcohol users having a more dorsal locus for cue reactivity than the males, who tended to have a more ventral medial prefrontal cortex locus. And so if you think about that in terms of TMS treatment design, maybe then we want to shape another factor we want to put into our models where we place the TMS coil is actually maybe we should shift it up a little bit for our females, whereas it should be down a little bit lower for the males. A great, strong graduate student in my lab, Dan McCallie, demonstrated that in a single session of TMS, the distance between the scalp and the cortex accounted for a huge percentage of the variance in the TMS-related response. So just measuring the distance between the scalp of the cortex and including it as a covariate in your linear model is a huge contributor to the final outcome. So I highly recommend that everybody do that. Additionally, Tanisha Kearney-Ramos, a postdoc in my lab, who's now faculty at Columbia University, demonstrated that that the engagement of the striatum at baseline was also a very significant predictor of TMS-related response. And that is individuals that saw drug cues and had really strong activity in the striatum component using ICA, they had the biggest TMS-related change. So this goes back to the theme of priming or engaging the brain causes a larger amplitude of TMS-related change. So to just sort of summarize this, we know that fiber tract integrity, this was another report published in Scientific Reports, that both white matter integrity and gray matter integrity in the area, in the vicinity of the coil, which in our case was the frontal pole, because that's where we're stimulating, had a significant effect on TMS-related change. Now, I don't know if that will necessarily generalize to other cortical targets like the dorsolateral prefrontal cortex. It could be something specific to the medial prefrontal cortex, which we know is also a factor for addiction relapse. But in as much as we're targeting the medial prefrontal cortex as a target for addiction treatment, we should all be taking into account gray and white matter density.
Colleen, we just have 1 minute.
Perfect. Okay, last slide. And so then one more thing I want to suggest, sort of with this theme of looking at structure and function, is looking at the stage of addiction the individual is in. So we have a lot of different circuits that we could target. And we know that people that are earlier in the stages of addiction, the behavioral mechanisms that promote relapse are different than more of the habitual stages of addiction, where people drink just because it sort of defines who they are and their behavioral repertoire. And so in closing, I just want to thank everybody that's sort of helped contribute to all this work. And we're now at Wake Forest School of Medicine, and we have a great team here. And that's all I have. Thank you.
Thank you very much, Colleen. It was a really, really nice presentation. It was perfect. So let's move forward to the next speaker, who is going to be Rita Goldstein and her postdoc, Pierre Olivier. So, Rita, do you want to introduce Olivier and the work that you are going to present today?
Yeah, so thank you for the invitation and being here in this webinar for the first time. I did want to say a few introductory words. Can you hear me?
Perfectly well, yeah.
Okay, great. And thank you for the beautiful talks before us. They were really very informative and inspiring and extremely interesting. So thank you. Just to introduce our group to everybody here, I'm a professor of psychiatry and neuroscience at Mount Sinai, Icahn School of Medicine at Mount Sinai in New York. We have been doing in my lab that I co-direct with Nelly Elia-Klein. Traditionally, we focus on neuroimaging of impairments in response inhibition and salience attribution, so the ERISA model in people with drug addiction. And what we will present today is our first foray into brain stimulation in people with cocaine addiction. And the presentation will be made by Pierre-Olivier Gaudreau, our postdoc fellow, who's been with us now basically for almost a year, right? He's coming with a PhD in clinical neuropsychology at the University of Montreal.
His advisor was Julie Carrière. He received postdoctoral award and also 3 awards from the Canadian Institute of Health Research. And his interests are in the brain connectivity patterns underlying sleep quality and individual differences. And in this first study for us, it was a small feasibility type of study. We were trying to, for the first time, see whether we can do repeated tDCS in people who are inpatients for cocaine addiction, expanding to 15 sessions, the usual type of 5 sessions of tDCS, trying to replicate the study of Esther Nakamura Palacios in Brazil. And without further ado, Pierre, Olivier, you can take over.
Thank you. I just need to have the access to share the screen. Okay, so thank you very much for this opportunity. It's really appreciated to be on this webinar. So as Dr. Goldstein said, today I'm going to present you the latest results of our tDCS clinical trial in cocaine in patients. So our lab, the neuropsychoimaging of addiction and related conditions, studies for several years now the impaired response inhibition and salience attribution syndrome, so the IRESA model, which encompasses impaired cognitive functions in drug-addicted individuals. More specifically, those drug-addicted individuals show a reduced inhibitory control of automatic or maladaptive behaviors, as well as attributing excessive salience to the drug and drug-related cues at the expense of non-drug-related stimuli. Studies show both functional impairments, but also neuroanatomical changes in the brain, specifically in the gray matter. These studies highlighted the involvement of the prefrontal cortex, a key structure in the drug addiction cycle, through its regulating effect of higher order executive functions and the limbic reward system. As Dr. Goldstein said it, so recent brain stimulation studies propose that stimulating the dorsolateral prefrontal cortex may mitigate these impairments, especially in people with cocaine use disorder. Indeed, the use of tDCS showed a decrease in craving, risk-taking, as well as drug cue reactivity. Specific stimulation of the DLPFC with the tDCS is hypothesized to modulate the complex interaction between the prefrontal cortex and the dopaminergic central reward pathway. So therefore, with a partnership with a New York City-based medical device company called Soterix Medical, we tested the feasibility of an extensive protocol of 15 sessions of tDCS directly on site of a drug rehabilitation facility, expanding on previous shorter stimulation protocols. We aimed at replicating previous results in patients from a team in Brazil, where they reported a decrease in subjective craving, anxiety, and depression symptoms, as well as an increase in the quality of life. But we also wanted to explore the effect of repeated tDCS on measures of sleepiness and motivation to change, from the literature showing a specific effect of tDCS on sleep duration and quality, and the implication of the DLPFC in motivation studies. Based on previous findings from the group in Brazil, our main hypothesis was that real tDCS would decrease self-reported cravings, as well as symptoms of anxiety and depression, and we would see also an increase in the quality of life. So our laboratory office was installed at the rehabilitation facility, and we consented 28 inpatients with cocaine use disorder. 17 of them passed our stringent exclusion criteria and were randomized to either a sham or a real tDCS group. We lost only 3 participants, surprisingly, in the sham group, over the 5 weeks of the protocol. Both groups were similar in terms of demographics and drug use variables, except for the tDCS group that showed a better functioning on cocaine negative consequences, which, however, was not statistically found to drive any of the effects that I'm going to show you today. Our double-blind study protocol included 2 milliamperes stimulations over the DLPFC, right canodal and left cathodal, and participants were randomized to 15 sessions of 20 minutes of either a tDCS or sham every other day for 5 weeks. After randomization, all participants underwent behavioral assessments before and after the 15 sessions, and we measured daily as well as weekly measures of cravings, and we also asked our participants to come back 1 month after the end of the treatment. For sake of replication, we assessed anxiety and depression symptoms, measures of quality of life, as well as cocaine cravings. But we also evaluated the contemplation to change, the drug use, that usually range from I have no thoughts about quitting to I have changed my drug use and I will never go back to the way I used drug before. And we also included a delay discounting task, which is an impulsivity task measuring the ability to value delayed rewards and scales of daytime sleepiness. So we first saw a general improvement with inpatient state for self-reported cravings, the quality of the environment, as well as the impulsivity. So more precisely, we saw that both groups showed decreased cravings after the protocol. They also showed an increased assessment of their quality of their environment, which usually includes, for instance, the home environment, the feeling of freedom, and physical safety, as well as an improvement in the ability to value delayed rewards. One of our main findings is a specific effect of real tDCS in reducing daytime sleepiness. So the interaction showed a significant decrease in the tDCS group as compared to the sham group after treatment. Those results were also corroborated by the analysis of the reported number of hours of sleep the night before each session that did not show a significant 2x15 interaction, but showed a specific group effects where the tDCS group slept more hours than the sham group. And this difference was statistically significant later in the protocol, usually starting after the 5th session and being more consistent after the 8th or 9th session. tDCS treatment also increased the motivation to change the drug use. As you can see here, the real tDCS group showed more motivation to change, namely a better outlook on their pattern of drug use after 15 stimulation sessions, whereas it was not significant in the sham group. Finally, as for the 1-month follow-up, 12 participants came back, and our results showed a transitory effect of tDCS treatment on daytime sleepiness. More specifically, the decrease in daytime sleepiness that we observed after treatment actually came back to the baseline level after a 1-month follow-up. And unfortunately, we did not see any significant effects for the contemplation to change in our studies, really small sample size. Finally, in addition to showing feasibility of this protocol, inpatient treatment reduced craving and impulsivity and also improved the quality of life. In contrast to previous findings, there were no group differences in craving. This decrease in craving for both groups could be attributed to our sample characteristics, comprised of treatment-seeking individuals that lives in an inpatient facility, which is a really controlled and structured therapeutic environment. It is also possible that our craving measures reflect maybe an habituation and or floor effect due to the repeated nature of those questions. Therefore, probably more objective measures would have been more sensitive to any potential effects or interactions, such as drug cue reactivity assessed by EEG or event-related potentials. Also compared to sham, the tDCS decreased the daytime sleepiness and increased the motivation to change. Specific studies in sleep using brain stimulation found an increase in sleep quality and duration in various populations, such as the elderly adults, bipolar patients, and also in patients with schizophrenia. Studies also showed an effect of the transcranial electrical stimulation, enhancing specific sleep oscillations, such as sleep spindles and slow waves, that play a major role in cognitive functions, such as learning. Also consistent with the IRISA model, by targeting the right DLPFC, we could have modulated the top-down control of the PFC and enhanced the flexibility to learn alternatives to current strategies to maintain abstinence, which could in turn increase the motivation to change in the tDCS group. So in conclusion, our results highlight the high feasibility of such extended protocol by showing significant clinical effects of real tDCS on clinical outcomes, even in our small study sample. Our results suggest the potential use of portable and or remote tDCS as part of treatment for addiction in non-medical facilities. So I'd like to thank my mentors, Dr. Goldstein and Dr. Elliot, as well as our collaborators and everyone at the lab for the help in the testing at the remote drug rehabilitation facility, and also for their support in the project. Thank you very much.
Thank you, Pierre-Olivier and Rita. It's a really, really nice presentation and really nice study. We have probably 2-3 minutes to take few questions, if there is any question among the audience.
I have a question. Can you hear me?
Yes, Maria, would you introduce yourself and then go for the question?
Hi there. My name is Maria Ironside. I've turned my screen on so that you can see me, but I can't see it. I know I'm not visible, but that isn't intentional. I'm a researcher at McLean Hospital, and I use tDCS in depression. And I was just interested, it was a really interesting talk. I was just interested in what the specific montage that you used. Did you use the anode over the right DLPFC, or was it the other way around, more like the depression montage?
Yes, it was above the right DLPFC and the catolol on the left. So we focus on F3 and F4. So the company that we worked with had kind of a strap that really helped the placement of the electrodes right over these electrodes.
So it's the idea is the right DLPFC. Is that a typical addiction montage? I just know because the polarity is the opposite in depression. And
yes, addiction mostly. A lot of studies showed kind of better results with the right anodal, whereas the opposite. And actually, even with depression, I know that if you do the opposite, sometimes depression could be kind of a side effect of this type of stimulation.
And to follow on that, we followed also the publications of Esther Nakamura Palacios from Brazil. She started with the left stimulation, actually, left anodal, but she switched to the right after showing that the left anodal increased risk-taking in people with alcohol and use disorders. So it was also empirically driven.
So it is a different pathway, I guess, than the depression literature would suggest. I was just trying to
The hypothesis is that maybe we are actually targeting the VMPFC, if anything, like Dr. Zanger Bumi was talking about. So, and here we didn't have any imaging, any way to assess really that.
Thank you.
Good. Now let's move forward for the next speaker, who is going to be Vince Clark. And Vince, we are all with you.
Okay. Great. Okay, can you see my slide?
Perfectly well, yeah.
Okay, all right. Thanks so much, Meg, for putting all this together and keeping us moving forward. We really appreciate it. I appreciate it. So what I'll be talking about today is brain mapping and TES, but actually a somewhat more broader discussion. Partly because so far in our lab, we've made a number of attempts to use electrical and magnetic stimulation to impact behaviors associated with drug use disorders, addiction, and so on, and haven't actually made much progress, which is a bit frustrating for us. But we've done a number of studies combining TES with mindfulness, and it really hasn't benefited the effects of mindfulness yet. We've tried to improve delayed discounting, which is an important aspect of drug use disorders. And again, nothing's come through. We've shown that TES improves mood, but in fact, when we look more closely, we realize that just putting the electrodes on the scalp was all that was required. They didn't actually have to be turned on. So not much to report here. I could end here, but I'm not. How do we move forward? So the biggest effects we've seen so far with TES are to enhance learning and memory. And we found between a 2- and 4-fold improvement in behavior over a series of studies across labs using TES to improve learning and memory. And the process we went through is we developed a stimulus set where people had to learn to identify threats in a virtual environment. This is one example of those stimuli. We started out with an imaging study, identified brain areas that were involved in learning to do the task, targeted those with transcranial direct current stimulation. And when we did that, we found a doubling of performance improvement with the same amount of training. This was replicated independently, semi-independently, in another laboratory where they found the same improvement in hit rate, halving of false alarms, and more than doubling of D prime to detect threats. More recently, we've developed another stimulus set using the same tDCS protocol, which was anode over the right temple against the left arm 2 milliamps of current for 30 minutes. And with anodal current in this case, we had people identify where in the world pictures came from. So they had a choice of 2 countries, and they had to determine which country each picture came from. It was a very difficult task. With anodal current, there was a nearly 4-fold improvement in learning to categorize these pictures. With cathodal current, slightly less of an effect, but still a significant effect. So using what we've learned from improving memory and learning, what can we do about addiction? We feel that using neuroimaging was an important guide to be able to apply tDCS, non-invasive brain stimulation. And we've done some imaging studies in drug use disorders. And so now we're thinking these might make a good guide for the work that we're doing with brain stimulation. So in a study that we published about 6 years ago, we found that neuroimaging, specifically functional magnetic resonance imaging, could predict relapse in recovering stimulant addicts. And we found that areas in posterior cingulate, insula, and anterior cingulate could predict relapse with close to 80% accuracy. If we added a history of mania, that went up to close to 90%. So it was highly predictive. And let's see. Oops. And other studies have found similar effects in posterior cingulate, also insula and anterior cingulate. So these are relatively consistent findings across studies. So how do we target the PCC with non-invasive brain stimulation? tDCS could potentially be used, but all electromagnetic phenomena follow laws governing electromagnetism. And there's a number of issues there to be able to control these electrical and magnetic phenomena to go deeply in the brain. So TMS and TES can only be used effectively for superficial targets if you're worried about stimulating other areas. So we saw Abraham's talk first today, and he talked about using TMS deeply. You can do that, but not without also stimulating a large number of other brain areas. How can we do it specifically and precisely deeply in the brain? So we're actually looking at a number of forms of energy that can be used for non-invasive brain stimulation. And this, if you go on Wikipedia and type in energy, this is a list you get. This is a list of pretty much all the energies that we know about. Chemical energy is pharmacology, and that's what we've been using mostly for the last century or so. Electrical and magnetic energies are what we've done most for non-invasive brain stimulation. But in our lab, we've also looked at mechanical wave, sound wave, and radiant energies. What I'll be talking about today is a possibility of using sound waves, so ultrasound, for non-invasive brain stimulation to target deeply in the brain. So we've known for nearly 100 years that high-frequency sound, what we now call ultrasound, affects biological processes. So Harvey in 1929 published a paper in frogs showing that he could affect frog physiology, heart rate, and so on using sound waves. Why should we use ultrasound? Well, anatomic specificity is one aspect that's important. So if you look at tDCS, not HD tDCS, but regular old tDCS, TMS, you see a relatively broad swath of tissue that's being stimulated. With ultrasound, modeling suggests that you could stimulate areas smaller than a centimeter superficially. And again, tDCS can go deep in the brain. It's not that it can, also TMS, but it's impossible to direct it to specific locations deeply in the brain without stimulating a number of other areas. So, but with TUS, with ultrasound, using a number of emitters that are all focused at a deep location, their additive sum will be deep, but more superficially, you'll have less of an effect. Now, ultrasound has been used in humans for many years. Almost every person in North America now, when they were a fetus, have been imaged with ultrasound. And we used a device that is developed for doing imaging to do our first ultrasound studies. And Ben Gibson and Jay Sanguinetti found that 2 minutes of ultrasound increased MEP amplitude, a measure of brain excitability, by about 30%. And that lasted for between 6 and 11 minutes after stimulation. So now we're thinking of developing ways to apply ultrasound to posterior cingulate. And we've done a number of pilot studies so far. This is our setup. Bashar Badran and his brother took a bicycle helmet and modified it in a way that it could hold an ultrasound emitter. The ultrasound setup consists of an oscilloscope to watch the ultrasound signal, a system that generates the ultrasound signal, and an amplifier. And all that gets hooked up to an emitter, and the emitter has a focal length. So in this case, 7 centimeters. So sitting on the back of the head, it's positioned in a way that's meant to target the posterior cingulate. Now, to verify that we're actually targeting posterior cingulate, we used MR spectroscopy. And this shows what's typically done is single voxel MR spectroscopy, but we're actually using something called EPSI, which is 3-dimensional spectroscopy. So what spectroscopy can be used for is to look at the concentration of different neurometabolites that produce a signal. And it's a subset of the many millions in the brain that produce large signals. But this gives you a swath of information about neurochemistry. Now, doing this with ultrasound in a pilot study, we found that using a protocol that is thought to be inhibitory, that we could reduce creatine, choline, and a combination of glutamate and glutamine nearby the target of the ultrasound. So this shows that we're getting target engagement, that posterior cingulate is being affected by ultrasound. So what's the future of brain stimulation for addiction? I believe that new methodology is going to be part of that. People are doing a lot of great work with electrical currents and magnetic stimulation that won't go away, and those technologies are far more developed for neurostimulation right now. But ultrasound, and I didn't talk about it, but we're also doing studies with low-level light stimulation. Might have certain advantages over electromagnetic stimulation. So new methodology, I think, is going to be a big part of the story in the coming years. Aside from electromagnetism, there's a number of forms of energy that could interact with the nervous system and produce beneficial changes, ultimately reducing drug use. Another is combining neuroimaging with neuromodulation. And this will be the 6th year in a row that we've held BrainStem. This year was supposed to be in Finland, but it will be online. And it'll be free, and it's next week. So if you're interested, please go to brainstem-meeting.org, and it'll give you information about how to register and how to get access to a number of great talks. And thank you very much.
Thank you very much, Vince. It was a really inspiring talk, lots of great potentials. Thank you very much. And your brain stimulation meetings are really, really good meetings. I hope that we will have this opportunity to attend in your meeting next week. Okay, we have 2-3 minutes for taking 1 or 2 questions.
I'll ask a question. about, ultrasound so far has been established as a way to induce ablations. This is very established method to induce ablations, but in terms of really doing brain stimulation, as far as I know, it is still a little bit questionable. My question is, when you see these reductions in glutamate metabolites, isn't it possible that you actually are seeing some micro ablations that cause that?
So, yeah, anything new is always suspect. Although, again, ultrasound as a neuromodulator has been known for nearly 100 years now. The amplitude of stimulation that we use is about 30% of the FDA guideline imposed for doing imaging in fetuses. So it's extremely low. In work in animals and studies in humans, no one has found any kind of damage associated with ultrasound. So it's not likely to be causing any long-term effects. So also to cause ablation, you need much more energy in the ultrasound than we're using by many orders of magnitude, actually. And a lot of the ablation studies also inject microbubbles or microspheres into the blood to be able to concentrate that energy into the blood-brain barrier. So we're obviously not doing that. So great question, but as far as we know, this is very safe so far.
Good, very good. So let's go for the next talk. That would be from Elliot Stein's lab in NIDA and one of PhD students. So if I'm not sure Elliot is going to introduce Sarah or Sarah is going to start. I mean, Elliot.
Sure, I can start my words. Hi, everyone. Ahmed, thanks for inviting me and for putting this together again. It's been great. Hi, everybody. So I thought that my lab is at the Intramural program at NIDA. Historically, we've done mostly mechanistic studies with neuroimaging, looking at basic neurobiological mechanisms of addiction, concentrating on various state and trait differences, mostly with nicotine as an exemplar. A few years ago, we started getting more into the interventional world. You guys were very inspirational for us. We've moved into both, again, basic mechanisms, as well as we have a new treatment study using TMS in cocaine addiction. Hopefully we can get back to you in a few years on that study. But our interest still remains in basic mechanisms, and we have, you introduced Han Bing a few minutes ago, and he's been doing some very nice basic mechanisms using an animal model, a preclinical model of TMS. We're doing the same thing with a simultaneous TMS and an fMRI inspired by a lot of the work that Colleen has done over the years. And then we wanted to get into, again, before we got into the treatment field, wanted to, again, understand some of the basic neurobiological changes that occur as a consequence of acute tDCS. And that was the work of Sarah, who will be talking in just a moment. Sarah was a PhD student in the lab. She just defended her thesis. Congratulations. Is getting a virtual hooding, I think, next week. And then returns to medical school to begin her M3 year in a month or so in the middle of a medical mess. So good luck to Sarah. So I think I'll just turn it over to her and let her talk about her study.
Hi, everyone. I think I need the permission to share screen, if that's okay. Can everyone see that?
Yes, perfect.
All right. So thanks again for having us today and for all of the wonderful presentations so far. So for this talk, I'm going to discuss how our research group has applied simultaneous tDCS fMRI to explore how tDCS may be used to alleviate cognitive circuit dysfunction and addiction, and specifically the nicotine withdrawal syndrome. So we know that the nicotine withdrawal syndrome is an important barrier to smoking cessation. Symptoms of withdrawal include cognitive, affective, and somatic signs, and these peak within 1 to 2 weeks of quitting, when smokers are most likely to relapse. And failures to quit smoking during this time period are attributed to the negative reinforcement pathways and symptoms that are associated with this withdrawal syndrome. We talked a little bit before about current therapies for smoking cessation and how these tend to not be as effective when you examine quit rates, especially at a time point of just 6 months. So here I'm showing the quit rates for nicotine replacement therapy, varenicline, and bupropion. And even with the highest rate with varenicline, there's still more than 2/3 of patients who are unsuccessful at maintaining smoking abstinence at 6 months. And so perhaps it could be useful now for us to shift our approach to this problem to consider addiction as a problem of dysfunctional large-scale brain circuits in addition to a pharmacological issue. And so this opens opportunities for alternative treatments such as tDCS. So for our study, we asked the question of whether tDCS can modulate 3 large-scale brain networks that are considered to be dysregulated in psychiatric disease, including nicotine addiction. And this model is based on Vinod Menon's tripartite network model of psychiatric disease, which our lab has substantiated within smokers, especially as a function of sated and withdrawal states. So these networks include the executive control network, default mode network, and salience network. The executive control network is considered to be task positive, involved in things like working memory and planning, including areas such as the dorsolateral prefrontal cortex. And the default mode network, which is considered to be anti-correlated to the executive control network, is more active in self-referential thinking and involves regions like the ventromedial prefrontal cortex. And then finally, the salience network is involved in integrating signals homeostatically and environmentally in order to allocate attentional resources to other areas of the brain, such as between these 2 networks. And what we found is that for smokers in withdrawal, there appears to be a weakened connectivity between the salience network and executive control network, leading to reduced cognitive control, and enhanced connectivity between salience network and default mode network, leading to increased negative affect and craving. And so the hypothesis here is that perhaps we can ameliorate some of this network imbalance by applying brain stimulation, for example, excitatory anodal tDCS to the DLPFC to enhance executive control network function, and inhibitory tDCS, such as cathodal tDCS to the VMPFC to downregulate default mode network function. And we tested this hypothesis using a sham-controlled, blinded, and randomized study of tDCS in smokers and non-smokers simultaneous with fMRI scanning of cognitive tasks to assess each of the 3 networks. And then we compared our active condition, which is shown in this figure on the right, to a condition in which polarity was reversed between the electrodes, and then also a sham. So just to summarize the design of the study, 43 participants participated in the study, 15 smokers completed, and 28 matched non-smokers. And all subjects completed these 3 tDCS sessions within a day in a randomized and blinded order. And smokers attended 2 different study days, each following 12 hours of nicotine abstinence, in which they received a nicotine or placebo patch the morning of the visit to measure sated and withdrawal states. And the patch was also randomized and blinded. And now within each of these tDCS MRI sessions, we collected a lot of scans. Today, I'm just going to focus on 2 of the cognitive tasks. This is the NBAC working memory task and the flanker cognitive interference task. So we use this flanker task in order to probe the salience network. And then we used the NBAC task in order to probe the executive control network and default mode network. So as part of this study, we collected behavioral and imaging outcomes. This is showing our behavioral outcomes on these 2 tasks, which included response speed and accuracy. And whenever we did these analyses, we divided this into a trait smoking analysis and a nicotine state analysis in order to assess the factor of trait smoking by comparing non-smokers to sated smokers, and the factor of within smoking nicotine state, meaning a stated or withdrawal condition. And so this slide is a little busy, but there are a couple of takeaways I want you to get from it. First, our pictorial ANOVA did not reveal any tDCS effects on these behavioral outcomes, but we confirmed that our tasks produced the expected results based on task difficulty, such as with increasing difficulty of the task shown by the increasing gray darkness of the bar. Participants consistently become less accurate and become slower across both tasks. And also within the withdrawal condition for smokers, they perform less accurately as a main effect of placebo patch, and also more slowly as a main effect of that placebo withdrawal condition for both tasks. But while we didn't observe behavioral results, we did observe promising imaging results of tDCS. So first, we observed an effect on the flanker task in which we found that tDCS modulated activity in a regions of interest analysis. So for this regions of interest analysis, we assessed activity in the bilateral insula and in the ACC. And we found that anodal DLPFC tDCS enhanced task-related activity in the anterior cingulate compared to the other two conditions of tDCS, which were that reversal of polarity and sham. And this was a main effect across all 43 subjects, regardless of group. So you can see this dark blue bar has enhanced activity compared to these other conditions. And then more specifically, we found this effect was strongest in the smoker group compared to the non-smoker group. We know that the ACC is a key node of the salience network and is involved in decision-making circuitry, and that these networks are considered to be aberrant in smokers. And so enhancement of the ACC by anode over DLPFC tDCS is of importance when we're considering the clinical potential of tDCS as a smoking cessation aid. Additionally, we found that for the NDAC task, although we didn't observe an effective tDCS within executive control related regions of interest analysis, we saw an effective tDCS on a default mode network when we performed a whole brain exploratory analysis. So this is again showing data from all 43 subjects, smokers and non-smokers. And what we found was a main effect of tDCS on deactivation of DMN nodes, and this was specifically an effect of the anode over DLPFC condition. And these nodes included parahippocampus, hippocampus, precuneus, and a variety of other regions. And you can see that this anode over DLPFC condition downregulated these default mode related regions compared to the anode over VMPFC or the sham condition. Further, we found a similar pattern of default mode network deactivation within the smoker group. And this had a similar regions that were deactivated, including parahippocampus, hippocampus, anterior cingulate, and other regions. But what was interesting here is that this deactivating effect of anode over DLPFC tDCS was most effective for smokers during the stated condition versus in the withdrawal state, where this effect was more variable and was not as didn't have as high an effect size. This is an interesting finding because it may suggest how tDCS could be most relevant therapeutically for smokers. If tDCS is most effective during a stated state, perhaps it should be used in combination with other replacement therapies or nicotine agonists, such as varenicline. And finally, we were able to do electrical field modeling for all of our 43 subjects individually. So this is showing all of those structural E-field models. And when we combined this on average, we observed a generalized prefrontal distribution of current density, with the maximal density being about 0.3 volts per meter. When we looked at the normal component of the E-field, we were able to better observe directionality of current flow such that the anode over DLPFC condition produced inward current flow over that general DLPFC region. And then there was outward current flow over the area where the cathode is placed over the right ventromedial prefrontal cortex. And the reverse was true for that reversal of polarity condition. So to summarize, while we did not observe an effect of tDCS on behavior, we did observe a strong effect of tDCS on neuronal activity as measured by bold fMRI. We consider that we may not have observed a behavioral response, perhaps due to the single session design of this study, and also perhaps due to low power to detect a small effect size, as you may expect with behavior. And then finally, we did observe a strong effect of anode over DLPOC tDCS on bold signal, in which tDCS suppressed the default mode network nodes during an NBAC task and enhanced anterior cingulate activity during a flanker task. Finally, smokers were more sensitive to default mode network suppression during the sated state when they were cognitively engaged in the task. And so this suggests that anode over DLPOC tDCS may be best applied as an add-on therapy alongside other types of nicotine replacement therapy or other pharmacological methods. And because we use the triple network model that applies to other psychopathologies, these results may also be further generalizable beyond smoking addiction. So thank you to everyone who participated in this work and who supported me throughout my graduate education, and I'm happy to take questions. I'm gonna just try to find it.
We have question. Marl, please.
Hi, thank you for that talk. I had two questions. I'm just interested in general for people who are doing work, let's say on tDCS for smoking cessation, the notion that you would be applying it when there is the least amount of craving. And I'm assuming most people who ran these trials had subjects in a state of high craving. I just want to hear more about that. Is that just as an idea, and also is that opposite to how most trials are currently run, where subjects are put in a deprived craving state?
Trying to examine. So for us, we were examining an acute single session design to try to specifically measure these neurobiological effects of tDCS. We weren't specifically looking at how tDCS affects craving in this study. So when we went in, I personally was expecting to see a greater effect of tDCS during the withdrawal condition versus the sated condition. So it was surprising to me to see that smokers were most affected during the sated state. But it may be due to, for example, when these smokers were in withdrawal, they weren't responding to the task. They were missing more trials. They were responding a lot less accurately. So it may be that they were more receptive to any intervention in general during that sated condition when they're better able to focus and engage these cognitive circuits. But it's certainly an open question about how do you affect craving and whether withdrawal versus sated condition, how do you apply it in a clinical fashion? So hopefully this moves a little bit closer towards a goal of a clinical application, but there's certainly open questions.
Okay, good. Let's go to the last part of the webinar. So let me see if I can share my screen. Okay, we had really nice presentations from different speakers across the world. I'm going to give you a few small updates from my lab as something like the last part. We have done a trial with tDCS, with fMRI tDCS. So we have done fMRI pre-post tDCS, sham and active. And meanwhile, right now we have finalized the trial, we are now doing the analysis. So we realized there are challenges in terms of how we can combine basically head models and individual dosage of the electricity that we provide for different people and their fMRI activation. So we are trying to work on that, kind of how we can combine the imaging fMRI outcomes and what we have in the head models. And we are working on that with Marom's team and kind of his students. We have recently published a methodological paper discussing about potentials in the field and the challenges and some of the kind of the case studies that we have done, trying to see how we might be able to do this sort of integration and individualization in terms of response to the different levels of electrical stimulation that we have in different parts of the brain using fMRI. So one of my PhD students who's working with me, she's a brilliant student, Ghazali, is going to present few findings, few kind of initial steps that we are doing right now in terms of integrating computational head models with fMRI in the network level. So these are basically the initial steps, just some kind of methodological steps. But I was thinking that might be interesting for you guys to see what we are doing for that. So Ghazali, are you online? Okay, just getting sure that you have the slides.
Sure. I can't share my slides.
Apparently is going to give you the screen.
Now you have the authorization, I guess.
Okay, good.
Can you see my slides?
Not yet.
I can't share.
Are you sure
So
that
let me make you the presenter once again. So you are the presenter now. Do you want to try it once again?
I click on the share button, but I couldn't share my slides, unfortunately.
So let's see what. Let me try something. So can you try it once again, Ghazali?
I can't share. I think Dr. Fiari has my slides. Probably he can share.
Download your slides. I do not have it on this computer. Let me see if I can have that. One thing that we can do, we can basically postpone it to the next webinar that we have.
No, I think I can share. I really like to present.
Do you want to try to? Let me see if I can download your slide. Just see if I can do it so fast.
I think now I can share. Can you see my slides?
Yes, we can see them.
Okay.
If you're having a problem with your internet connection, you may want to maybe turn your webcam off, so it may help with your internet connection. So
of course.
Good. Now we
can you see my?
Yes, go ahead.
Thank you so much for your great presentations, and I'm really excited to have this opportunity to present one of our recent research here. I want to talk about group and individual level variations between two similar DLPFC electrode montages for tDCS, and based on a network-led approach and computational head models. As you know, tDCS is the most investigated therapeutic technology in neuropsychiatry, and we know that despite the positive effects of tDCS in, for example, addiction medicine or many other neuropsychiatric disease, a complicating factor is its heterogeneity and large inter-individual variability in response. And it seems that this variation is not the exception, but the rule. And as Dr. Colleen mentioned, there are many sources of variations in response to transcranial brain stimulation, and one of them is electric field distribution patterns based on brain anatomy and electrode montage. And MRI-based computational head models can be considered as a good indicator of these two factors that predict how brain anatomy that varies from person to person and determines electric field patterns for a given electrode montage. Based on this brief introduction, we considered two similar and two common frontal tDCS montages that nominally target the dorsolateral prefrontal cortex. And based on a recent systematic review as a first output of INTAM network, we know that these two electrode montages are commonly used in addiction medicine. One of them was a unilateral or asymmetric stimulation of the LPFC with anode over F4 and the cathode over contralateral supraorbital area, and the other one was a bilateral or symmetric stimulation of the LPFC with anode and cathode over F4 and F3 locations in EEG standard system. In order to compare these two similar electrode montages, we simulated computational head models for 66 participants with methamphetamine use disorders based on their T1 and T2 weighted MR images. And as you can see, we found inter-individual variability in response, and our conventional tDCS, I mean a large electrode packs, produce diffuse current flow through the brain. So we can say that stimulation outcomes may be considered as a modulation of global networks. Therefore, we considered a network-led approach instead of region-led approach. Majority of previous computational head modeling research about the importance of electrode locations were based on whole brain or region of interest analysis of computational head models, but we know that stimulation outcomes are not restricted to a single region, and many distributed brain regions interact with each other through the brain networks. Therefore, we think that network-led analysis of computational head models maybe provide better information about computational head models. And after creation of computational head models for each individual and transformation to a standard space for group-level analysis, we applied a network-based parcellation with Yeo atlas to extract electric field intensity from 7 large-scale networks. And the next step, in order to determine electric field intensity in each network node, we applied a final parcellation and we determined electric field intensity in each node. As mentioned in previous slide, we know that each node of these networks play important role, for example, in addiction medicine. In this slide, you can see that we found some significant differences between two electrode montages. We defined a threshold based on 50% of maximum electric fields, and we found that only linked networks showed significant differences between two electrode montages, and you can see that each montage is marked with a color, red for symmetric and blue for asymmetric electrode montage, and you can see that asymmetric electrode montage produced a higher electric field than the symmetric montage. And in the right side, you can see that besides between montage variations, we also have within montage differences. We have some subjects whose electric fields change extremely little or oppositely compared to the group level electric field intensity. And based on our final parcellation, we found that some specific nodes in a network that show significant differences, even if there is no significant difference at the network level. For example, we said that Linux system was the only network that shows significant differences between two montages, but we found significant difference in, for example, the frontal operculum insula in ventral attention network or in the LPFC node in executive control network. And we know that each network is a very important node for our analysis, for example, about addiction and something like that. In some our study, just wanted to say that we wanted just generally demonstrate a methodology for considering the components of large-scale networks in computational head models instead of targeting a single region. And we think that electric field intensity in each main node can provide more information about our simulation. And specifically, we provided new insight into how symmetric versus asymmetric frontal tDCS may differentially modulate network across a population. And in our future study, we want to combine our results with fMRI data, for example, with functional activity in each main node of a network, and, for example, behavioral data that we had. And I just want to mention some of our results here. And thank you so much.
Great, thank you, Panyan. Really nice presentation. So as you can see, we are kind of developing a pipeline to be able to integrate the computational head models that we have with the fMRI data in the network level. And these are basically the initial steps. So I think that even the initial steps are interesting to be shared, and those who are interested to basically have the same pipelines, or if you have the imaging data, we definitely would be happy to help you to use the same pipeline to see the individual differences. So let me show you a few other last updates that might be interesting for people who are here. Okay, let me try to share my screen. Okay. Today we have been kind of discussing about drug Q reactivity a lot. Bumi was discussing about the effect of Q reactivity, and Colleen and others. So we have recently developed a new database for meth and opioid Qs. And we have recently published a paper, and we have put all the database, the entire database, in a GitHub GitHub link, so you can have the access to the database. And this database has 360 images, both meth-related pictures, opioid-related pictures, and control images. And we have controlled them for everything. So we have done intensive validation. So the validation that we have for this database is more comprehensive than the IAPS validation, if you are familiar with the IAPS database. This database is pretty much well validated. And then we have developed some fMRI tasks with basically for opioid users, with the control images as well, and also for meth. And we try to develop them in a way that the meth and opioid would be equivalent as well. So we can then kind of see the activation in the meth pictures and also opioid pictures among different groups and compare them together as well. And then we develop basically 3 versions of these tasks. So right now we have 3 versions of fMRI tasks that have both meth pictures and opioid pictures, and separate kind of tasks for meth users and opioid users. But they are technically equivalent in terms of the psychophysics features, in terms of their craving, balance, arousal. Those features are basically controlled among these tasks. And that would give us this opportunity to basically kind of also publish the fMRI results of what we have with these tasks in the whole brain, basically atlases, and also in terms of different regions across the brain in the brainotome ROIs. And we have also tested the retest reliability of the kind of the one of the tasks that we have here in the package. And as you can see here, there are something like 22 areas that we have with ICC above 0.5. And you know that in the field of fMRI right now, task-based fMRI, something like above 0.5 would be a reasonable sort of kind of reliability for the task. And also we have tested whether we can use that separately in meth users and opioid users, and we showed that they could be used in both groups. And there are significant, there is no significant difference between meth users and opioid users in terms of the database. So the database is available. That might be something that people would be interested to use if they want to use the pictures, or if they want to use basically the fMRI task. Even we provided the fMRI, the codes for the fMRI task, so people can use that resource. And as the last slide, right now we have started to discuss what would be the best things to do for the next INTAM webinar and how we might be able to move forward. So we have been discussing with Colleen to see what are the basically targets that we can think about for the next webinar in terms of promoting discussions inside the community, and how we might be able to bring people together to kind of discuss the main challenges that we are facing right now in the field. So we have few minutes to discuss about that. If people are interested to share their ideas or what they suggest in terms of what are they suggesting for the next webinars and what we can do, and even what are the speakers that they suggest to be invited.
If I may comment on this, Ahmed.
Sure.
My impression is that it will be very useful to agree on parameters to use in clinical trials, because my impression in this field is that there have been so much variability that it's very difficult to compare and combine. And So I think the most useful thing to do will be to agree on parameter for design.
What are the other thoughts? I mean, others who are kind of in the meeting, or specific notes from the speakers, or
Well, with the COVID pandemic, I would talk about remote administration and remote long-term home self-administration and parameters that we need to use, maybe standardizing that. But I'm sorry, I will have to leave probably in the middle of a discussion for another meeting. Thank you so much for this webinar.
Thank you. Any other suggestions?
Hamid, this is Basant from New Jersey.
Please, go ahead.
Thank you for doing this. This is very stimulating. My suggestion is basically because brain stimulation in non-invasive method provide a unique opportunity to combine with other modality like mindfulness meditation, to design a protocol and improvise that with combination modality rather than single modality.
Okay, good. But what are the other suggestions? Other people who are already online?
I have a suggestion in terms of focusing perhaps the talks as source of brain stimulation and what it does. Because, you know, what does it do? I mean, I think in our study, all of these results, you know, to me, it says, okay, perhaps this type of brain stimulation, what it does, it facilitates learning. So it evokes plasticity in the brain, and that plasticity facilitates whatever the person is learning at the time. That could be one thing. So if you expect that this type of brain stimulation facilitates learning, then you won't use it as a target to reduce emotional types of things, but actually to induce more cognitive exercises, etc. So, you know, we're still not there. We still don't know exactly what it's doing.
What are the other suggestions that we have from people in the room?
Just want to comment on what Nelly just said. I think we don't know yet even what ECT is doing. We are using it for 100 years to treat depression. And there have been more than 1,000 people who did PhD on mechanisms of ECT. And yes, we have some aspects of understanding of what we're doing, but it's a very high bar that you're putting here to really understand exactly what we are doing in a few years.
I mean, I do like the idea of having maybe mechanistic talks, but also talking about the whole COVID issue. I mean, I'm not sure, you know, is anybody on this call running trials? How severe are the shutdowns? And we did publish the document, but it was a little bit abstract. And I think to have someone, let's say, who is running an active TMS center, go through the nitty gritty of like, you know, are they wiping down their coils? You know what I mean? Like what are they doing? You know what I mean? And same thing with remote tDCS, almost like a hands-on walkthrough might be useful. And also, you know, if people are shut down, it's also very timely. Again, I don't know, we can talk about the severity of the shutdown, but I'm just, who's running, you know, who's treating patients with addiction?
Colleen, please.
I was just saying, I mean, we can talk. You probably don't want to hear me talk again, but if you need somebody to talk about that, we are running our alcohol study now and probably our pain study in a week or two. So we could talk if you want.
Yeah, even
it very much depends where you are, right? It depends where you are and where the pandemic is where you are. The ability to run subjects. But one possibility is to bring the lab to the subject. So if, for example, you're working with inpatients, you can bring, you know, things like tDCS, you can bring to the patients and teach them. So you have one exposure where you have to teach them how to use it, etc. And then you can, you know, there are enough people in the facility to make sure they use it, etc. So that could be an avenue.
Related to that, just like an anecdotal struggle that I'm having at the moment is I have someone with a home use kit ready to go, and it'd obviously be ideal to be able to do home use in the current times, but this person, because of the current situation, doesn't really have any private space in their home to be able to do the treatment. So that's become an issue, and we've been unable to progress with that specific person for that reason. So there's really a lot to think of in terms of, people needing privacy for treatment, as well as, obviously the safety concerns.
Yes, I think the practicality of all these issues, again, how Colleen is, I don't know, is she cleaning her chair? Is she putting a plastic bag over the TMS coil? These issues are regional, but they're also device specific, right? So for figure of 8 versus for deep TMS, there might be different things that you need to do to keep operations going. And then also, so I think in clinic TMS and home, to have, an emphasis on, if people can wheel in their TMS machines or whatever, or have pictures of what they're doing step by step, and then having people have the opportunity to ask, do you wipe this down? Do you use alcohol for that? It could be interesting. It could be useful.
Of course, but and then meanwhile, there are different policies, different institutes. For example, in our institute, we have already started to develop our in-house COVID-19 testing system. So we are going to test every single individual who is going to be recruited for any trial, and they would be waiting here for something like 1 hour. If they are clear, then they can go for the trial. So that is, we will see how those things are going to work. But even at that level, our institute is requiring us to basically do the testing for the subjects, and we inform subjects that this is not, let's say, clinically approved case testing. It's like the imaging that we do. It's not kind of clinically kind of approved, but that is the way that we try to screen that. That's the policy that our institute is taking right now. And we are, from the next week, we are going to start scanning with our students, basically some technical scans that we have, because we are doing the TES fMRI inside the scanner, concurrent TES fMRI. So we are going to do that with the students, and then moving forward with the patients in probably 2-3 weeks. But technically, that is the requirement that our institute is asking us to do.
Yeah. These things are so timely. I know, I heard Mount Sinai is opening up soon. So I'm like, are you know what I mean? So they are, you know what I mean?
For basic studies, not human clinical research, opening only for basic.
Yep, good. It seems that we still have lots of really good discussions. So if you have a specific suggestion, please feel free to send your suggestion to the INTAM email that you are already receiving emails from INTAM email. So just send us an email to INTAM, and we definitely would be happy to see how we can share the experience that you have or document that you have. As Mauro mentioned, if you have developed a specific protocol for your own lab in terms of how to clean up the TMS code or those types of things, we definitely would be happy to share those post protocols with other labs, and that would definitely be helpful. Meanwhile, the document that we put together, we are going to release the new versions of that document, so we can kind of make some like amendments based on the kind of the experience that we are receiving from other labs. So we definitely would be happy to add your experiences to that specific document as well, as much as we can. So that might be another potential for that. But we definitely need to work together for the next couple of weeks, getting sure that how we are going to reopen and also open new potentials with the basically home-based technologies, and how those home-based technologies could be helpful for the people in the field. Good. Thank you very much, everyone, for attending. We had more than 100 kind of people in the meeting today. Hopefully, we will be back for the formal 5th kind of INTAM webinar in September. And we have already started to kind of invite a speaker. So if you have a specific speaker you'd like to invite, just let us know. So hopefully we will be back together formally in 4 months, but we might need to have another kind of extra webinar if we kind of realize that we can kind of share some new protocols for kind of brain stimulation during COVID-19. So we will probably arrange something as soon as we can get sure that we have enough evidence for that, and we have enough people who are interested to share their experiences. We definitely plan for that as well. Thank you very much, and have a good day. Take care. Bye-bye.